Good afternoon. I bring greetings from Surgery Unit 6. It's the first time that we have come for the CCR. We have already celebrated our happy birthday, first year. So, so we all doctors are puzzled at times. What we are dealing with, human body is full of mysteries. And one such case, which was again such mystery, clinical to sort, and not one department, there were many departments, all brains together. They put their best foot forward to diagnose this case and do the best for this patient. So I invite Dr. Jinder to give the details of the case.
Good afternoon, everybody. Our patient is a 43-year-old gentleman, twice operated for an intracranial hemangiopericytoma with a ventriculoperitoneal shunt, presented with chief complaints of recurrent episodes of sweating, palpitations, altered sensorium, and loss of consciousness, requiring frequent hospital admissions. And after admission and thorough workup, he was diagnosed with hypoglycemia, attributed to his symptoms with the lowest documented value of 11 mg per deciliter, associated with increased history of increased food intake and a weight gain. All the above mentioned symptoms, they were present from the past 6 to 7 months, and the patient was not a known case of diabetes mellitus and was not on any kind of diabetic medications or injections. Provisionally, the patient was diagnosed with excess insulin secretion for unknown origin and was managed initially by dextrose infusion and IV steroids in the Department of Endocrinology. In the past history, the patient underwent craniotomy twice, once in 2014 and another in 2017, for an extra-axial space-occupying lesion. And second time, he also underwent VP shunting, and on post-op histopathological examination, both of the times the patient had a diagnosis of hemangiopericytoma, WHO grade 2. On clinical examination, patient was well oriented to time, place, and person, and was on IV dextrose infusion while he was admitted in the Department of Endocrinology. No cyanosis, lymphadenopathy, and clubbing was seen, and the patient was afebrile. All the vitals were within normal limits. On systemic examination, all the systems were within normal limits, and on per-abdomen examination, there was a surgical scar of the previous VP shunt and a vague palpable lump in the left upper abdomen extending into the left lumbar and umbilical region. Blood investigations were done, and all of them were found to be within normal limits. Hypoglycemia was documented clinically and biochemically through a Whipple's triad that includes symptomatic hypoglycemia, plasma glucose levels of less than 55 milligram per deciliter, and the reversal of symptoms after IV glucose load. Because of hypoglycemia, certain special investigations were also done, including the insulin levels, C-peptide levels, growth hormone levels, IGF-1, ATM, cortisol, and all of them were found to be on the lower side of the reference range, except IGF-2 that was not done because of the logistical issues. So in view of hypoglycemia and the history and examination part, we proceeded with the USG abdomen, which showed a large, well-defined intraperitoneal mass measuring about 15 cross 12 cross 10 centimeter, seen in the left perisplenic region. There was associated splenomegaly, and bilateral bulky kidneys was also noted. So after this, for better delineation and delineation of the mass and anatomical variations, CCT was done, for which I would like to invite Dr. Prabhat from Radiodiagnosis to discuss the CCT for this patient.
Thank you, Dr. Rajendra. Here in the CCT coronal and axial section, we can see a large soft tissue mass which heterogeneously enhancing with central area of necrosis, and the mass is centered in the lesser sac region, and the mass is closely abutting the pancreas, and mass reaches up to the anterior abdominal wall and it displaces the bowel loop anteriorly. So it's a heterogeneously enhancing mass with central necrotic area centered in the lesser sac. The differentials could be many, and here in the anterior abdominal wall we can see the VP shunt. So based on this lesser sac mass, the differential could be a pancreatic net, could be a gastric cyst, or it could be the remote possibility of a we have the cerebral fibrous tumor also intracranial fibrous tumor. So a remote possibility of BP cell dissemination into the peritoneal cavity, and there is a fibrous tumor in the lesser sac could be there. So from our radiology side, it's a large heterogeneously enhancing soft tissue mass in the lesser sac region. Now I will invite hemangioperisonoma in the brain. Sir. Yes, it happens in the brain. So the remote possibility could be the remote possibility. From our side, it's only a large heterogeneous energy mass centered in the lesser cell region. Now I will invite a proponent from nuclear medicine for further discussion. Thank you.
Good afternoon, everyone. For further evaluation in regard to hypoglycemia, the patient was referred to our department for gallium-68 Dotanov PET CT. The maximum intensity projection image and the CT and fused PET CT image in axial, coronal, and sagittal cross section showing mild SSTR expression in the large abdominal mass as described previously. Then two dural based soft tissue density lesion showing SSTR expression suggesting recurrence at primary site. Then multiple skeletal site metastases like right petrous bone, head of right humerus, D3 vertebra, sacral ala, right sacral ala, then left ischial tuberosity. In view of these findings, our first differential was the large abdominal mass could be a peritoneal seeding from the primary site, and the less likely possibility could be IGF secreting non-islet cell tumor.
With all these provisional imaging and biochemical investigations, we proceeded with biopsy of the lesion, which was suggestive of a neoplastic etiology consistent with solitary fibrous tumors. It was expressing CD34, BCL2, CD99, and STAT6. And from this, we arrived at a provisional diagnosis of non-islet cell tumor, hypoglycemia, query due to IGF-2 secretion. Secondary to it might be a hemangioparasitoma, or a fibrosarcoma, or a mesothelioma, or a pancreatic carcinoma. And patient was initially responding to steroid therapy in the Department of Endocrinology, but as he developed liver dysfunction and was not able to tolerate further steroid treatment, he was referred for a surgical management. The treatment option available were IGF-2 secreting tumor. It could be managed by either resection or debulking of the tumor, which is the ideal choice. And the other will be like chemotherapy and steroid therapy when tumor is not operable. Both these options can be considered. We planned a treatment of exploratory laparotomy and resection of the tumor. The goals were to excise or debulk the tumor, or to ensure normoglycemia to the patient, or else at least to reduce IV glucose requirement and improve his quality of life. The findings in laparotomy were there were dense segmental adhesions noted around the previous VP shunt area and a large 15 into 10 centimeter with increased vascularity noted in the retroperitoneum, which was encasing the tail of the pancreas and closely awaiting the splenic vessels. So we had to do we did a resection of the entire tumor along with the distal pancreatectomy and splenectomy, as it was encasing the splenic vessels completely and there was no plane for dissection. The surgical challenges which we faced were, it was a highly vascular tumor and it was closely abutting the major structures like the tail of the pancreas and splenic vessels. And the most challenging part was ensuring hypoglycemia throughout the surgery, which was very well managed by the anesthesia team. In the post-operative period, it was uneventful. Serial monitoring of blood sugars were done, which showed no further episodes of hypoglycemia and no further requirement of dextrose infusion. And abdominal drain was removed on day 5 and patient was discharged on post-operative day 10 uneventfully. I would like to call Anvo for histopathological description.
Thank you, Dr. Puneet. So on this gross, as we can see, this is the resection of complete tumor mass itself. And we can see a well circumscribed fleshy tumor. It was firm in consistency, and here we can see a central area of infarction. On the microscopy, as we saw in gross, the tumor is very well circumscribed with a thick fibrous capsule around it. And at one periphery, we can see the pancreatic tissue also. On low power, the tumor was cellular. And as we go on high power, we are seeing an ill-defined fascicular pattern with interspersed vasculature. The individual tumor cells were round to plump oval with a moderate amount of pale eosinophilic cytoplasm, mildly pleomorphic nuclei, and vesicular chromatin with inconspicuous nucleoli. So at this point of time, we were thinking on the lines of a low-grade mesenchymal neoplasm. IHC was done, and on immunohistochemistry, the tumor cells were diffusely immunopositive for CD34 and STAT6. We can see a very nice nuclear staining of STAT6. We also did markers to rule out carcinoma, neuroendocrine neoplasms, GIST, and other soft tissue tumors which were negative. So, on the basis of complete morphological and immunohistochemical profile, a diagnosis of solitary fibrous tumor was made. The previous histopath of the CNS lesion was also reviewed, and it showed a very similar morphological and immunohistochemical profile. So the final diagnosis of a metastatic solitary fibrous tumor was made with a primary in CNS. Thank you.
With this, with all these imaging histopathological findings, we finally solved the puzzle of hypoglycemia, as it was a metastatic solitary fibrous tumor which was secreting IGF-2. It could be arising from a drop metastasis of a previous BP shunt of previous surgery. And this is how biochemically we substantiated, as the insulin levels, proinsulin, C-peptide, IGF-2 were all within the lower limit of the normal. And this was how we substantiated the diagnosis of IGF-2 secretion. And currently, the patient has been free from hypoglycemic symptoms and has remained comfortable. Currently undergoing treatment in medical oncology with tab-azopanib 400 mg OD, which is a tyrosine kinase inhibitor and an anti-angiogenic agent for his metastatic disease. And he doesn't need any IV requirement or any symptoms, or are there any hypoglycemic episodes further. And recently he received a radiotherapy for his right humerus lesion, and now it is 9 months past surgery. This is the follow-up of the patient. And review of literature and discussion. There are various tumors which secrete IGF-2 and cause hypoglycemia, and there is a list of these things. And ours was a hemangioparasitoma or a solitary fibrous tumor, which has a prevalence of around 7%. Non-alert cell tumor hypoglycemia, it's a syndrome of hypoglycemia associated with any neoplasm other than an insulinoma. True incidence is exactly not known, and tumor might have an epithelial origin or a mesenchymal origin, and it is basically due to the overproduction of IGF-2, that is post-translational precursor, which is called a big IGF-2. This big IGF-2 activates insulin receptors at various sites, resulting in hypoglycemia. NICTH is characterized by hypoinsulinemic hypoglycemia, and solitary fibrous tumors are a rare mesenchymal neoplasms which produce this big IGF-2 and are known to cause hypoglycemia. This tumor produces a pro-harm form of IGF-2, that is big IGF-2, which also impairs the release of glucose into the bloodstream. And there are various paraneoplastic syndrome associated with this IGF-2 overproduction, and one of them is Pierre-Marie-Bomberg syndrome, which is a hypertrophic osteoarthropathy, which is observed in less than 10% of the cases and is often pleural-based related diseases. And the clinical features which occur are clubbing, hypertrophic skin changes, arthralgia, and increased periosteal activity. The other one is Doge-Patter syndrome, which is similar to our case. It's also a rare paraneoplastic syndrome occurring in less than 5% of the cases of solitary fibrous tumors, and usually symptoms typically resolve after surgical resection of the causative tumor. And this insulin-like growth factor 2 is produced in the liver. It's structurally related to proinsulin, and these are the various sites on which this acts to cause its effects. And this big IGF-2 competes with IGF-1 for its receptors and is known to cause hypoglycemia by acting on these various organs. And how to diagnose this case of non-islet cell tumor hypoglycemia? Initially, we should evaluate for hypoglycemia, which is confirmed by a Whipple's triad and glucose measurement of less than 55, and the symptoms gets corrected after IV dextrose or glucose infusion. And other common causes of hypoglycemia should be ruled out, like medication-induced, critical illness or organ failure-induced, hormone deficiencies, endogenous hyperinsulinism. All these should be ruled out before considering this diagnosis. And when to suspect NICTH? When all these causes are ruled out in a patient with a previous history of malignancy or identification of a large new mass, then who presents with a hypoglycemia, NICTH can be considered as one of the diagnoses of differentials. And the laboratory investigations, what should be done is serum glucose, insulin, proinsulin, C-peptide, beta-hydroxybutyrate, and any screening of hypoglycemic agents, and liver kidney function test. And if there is a strong suspicion, IGF-1, IGF-2, and growth hormone should be evaluated. And what will be the values of these? In these NICTH cases, glucose, insulin, C-peptide, proinsulin, growth hormones, and IGF-1 will all be in the lower limit of the normal, and IGF-2 will be increased, and IGF-2 to 1 ratio will be more than or equals to 5. And if lab facilities are available for testing of this big IGF-2 or proinsulin IGF-2, then it should be done. Then once all these parameters are evaluated, and we can localize the mass by either a CT imaging or other imaging modalities, and then evaluation can be proceeded further depending on the location of the tumor. And this diagnosis is supported by the presence of hypoglycemia, low insulin levels, and high serum levels of big insulin-like growth factor 2, usually associated with a single large tumor. And usually tumors more than 20 centimeter or above are associated with this hypoglycemic symptoms, and tumors with a high mitotic rate are also ascribed to it. And the management is usually a multidisciplinary approach, and surgical management is the definitive treatment. And Thiele et al. In this study described how these NICTH tumors can be treated by steroid infusions, and human growth hormone therapy also can be used, but low glucocorticoids are more better compared to this growth hormone supplementation therapy, which was initially tried in our case in the initial period of treatment. And when to consider chemotherapy in these metastatic solitary fibrous tumors? Patients who present with a synchronous or unresectable lung metastasis and who is having an extraperitoneal metastatic disease, and these are the patients suitable for medical line of management or chemotherapy. And usually anthracycline based drugs and ifosfamide or dacarbazine monotherapy has been used. And anthracyclines are usually used as a first line, and other drugs like ifosfamide, dacarbazine, and trabectedin are considered as second line options. And patients who are not able to tolerate these drugs, best supportive care is recommended due to drug toxicity. As these tumors are highly vascular and produce vascular endothelial growth factors and others, anti-angiogenic agents like sunitinib, sorafenib, azophenib, and temozolomide bevacizumab combinations are recently tried and being evaluated for the treatment currently. And Park et al. In this study advocated the importance of anti-angiogenic drugs like temozolomide bevacizumab combination as well as sunitinib regimes for the treatment of these metastatic solitary fibrous tumors. And Nussbaum et al. In this article highlights that hemangiopericitomas in the brain could metastasize and can cause this hypoglycemia. And Kelly Bretz et al. In this study reported a case wherein there was a seeding of abdomen with primary intracranial hemangiopericitoma by a VP shunt previously operated for the same. And he recommends using endoscopic third ventriculostomy as the primary treatment for intracranial solitary fibrous tumors or hemangioparasitomas who present with hydrocephalus to prevent the potential spread of these tumors via peritoneal shunt. Now I would like to call Kamal sir for concluding.
Okay. Thank you, Puneet. Beautifully explained the literature part. So it's time to conclude. By now, I think it must be clear that the IGF-2 secreting receptors, they arise in the setting of metastasis. So most of the times they are arising in our case, the primary was hemangioparasitoma, but it is not necessary. It will be hemangioparasitoma in all cases. It may be lung cancer, as shown by Dr. Puneet in the PPT. So our message through this presentation is that in any case who has been dealt with the malignancy, if presented with the malignant metastasis, then if he is having a features of hypoglycemia along with new onset of large tumor, in these two settings we should think of IGF-2 secreting receptors. And in this setting, surgery is always the mainstay of management. We should try surgery as a first step. Curative resection, if possible, is the best. If curative resection is not possible, then debulking is also role. It will decrease the IGF-2 secretions by decreasing the tumor cell. But there may be some scenario like where surgery is not an option. It is not possible. In those cases, medical treatment has got role. Our medical oncologist colleagues, they can help by giving chemotherapy as well as anti-angiogenic agent as described by Dr. Puneet. And these such type of cases, they are always managed by multidisciplinary approach. As it was seen in our case, there are many departments who helps us in managing this case. So I would like to thank the Department of Endocrinology, Radiodiagnosis, Nuclear Medicine, Department of Pathology, and Department of Anesthesia. So without their help, it was not possible to manage this case. So I again thanks to all of you. Thank you. So now the case is open for questions. Yes.
Normally, we don't ask the patient to take any sweet thing, food. It's a normoglycemic. That rule applies only for normoglycemic, not to the hypoglycemic patient. Patient was on glucose drip, and we injected FDG, and we got this scan down. So it is just not that, because it is a standard of teaching that if his patient is on anything sugar, you should not do FDG PET scan. That's the point I wanted to emphasize. And again, there's whenever you have got one tumor is there, always try to associate with the same tumor. That this case was several times discussed in our endonuclear meeting.
Yes, sir.
And then in that meeting, I still remember I told Nikhil, take out the tumor, at least patient will be benefited. So that's what finally.
Yes, actually, this case was lucky we were able to do curative resections. Otherwise, it is not possible in all cases. Yeah.
Symptomatically patient.
At least we were able to salvage the infusion.
But I told if the tumor is having big tumor and might be very close to pancreas, might be pressing, so take out the tumor, patient may be better. But finally, it turns out.
Thank you, sir. Any more question? Yes. Right. Right. Hemangioparasitoma. And it was finally proved in histopathology also. They were having same histopathology. Yes. So we are lucky to have new people. Yes, sir. दो बार. Two, 17, 2017. Second beyond me. Yes.
People were thinking that one is relying other to make it. But now they see molecular, they grade 1 to 3.
Thank you.